Hi everyone. So today I'm going to speak to you on antiretroviral resistance and managing treatment failure, particularly in resource limited settings. As everyone in this audience been known that these are the various antiretroviral drugs which are approved for use and which we have been using for our routine therapeutics. And also in this slide, I have put some striking mark. These are some of these drugs which we had used in the past. Now we are not using anymore because of the lack of efficacy or because of severe toxicity on an ongoing way. Thereby, we are bringing in newer medications as part of these treatment guidelines. So this is a recommendation by WHO in 2019, where majority of these regions have been following up. Now the new updates been coming up, where tenofovir combination of tenofovir with lamivudine or emtricitabine and dolutegravir is the preferred choice, which we all know that. And efavirenz containing therapy has been moved out of those preferred, and also the 2019 recommendations also been recommended in special population with TAF containing therapy. But now we have some data showing about those adverse events related to TAF, again, the preferred being TLD in resource limited settings. Now, coming to this resistance, as we all know as clinicians, when we take care of patients, when you put someone on antiretroviral therapy, what we have been expecting as an ideal response is the HIV RNA, the viral load, should get suppressed and should be sustained. So to do this, you need a potent combination antiretroviral drug, as well as lots of commitment from the patient population to adhere to this medication. But what's happening in a real world common response is when patients take it, get suppressed, when they take to miss the pills, they tend to have a blip. And again, when you counsel the patient, they take the medications, again get suppressed. Again, when they miss the medications, they can have a blip. So when they have more than 3 or 4 blips, it can end up in resistance. It's something based on previous studies. So to avoid this, we need a potent drug, as well as the patients need to take this regularly. They need to have more than 90% of their adherence to those medications to have this sustained suppression. Also, we know that when someone we put on antiretroviral therapy, we monitor them clinically, we do a viral load, we do a CD4 cell counts, and make sure that they're taking the drugs. And if they don't take it, we'll know from these various biomarkers that the drugs are not working. We completely counsel them and make sure that they take the drug. Again, you repeat the viral load and take a choice whether they're developing a resistance to these medications or not. So the first thing happens is virological failure when someone is not taking drugs, and which will be followed by decline in CD4. We call it as immunological failure. And if you don't identify this early and switch, they can end up in developing any of those clinical manifestations, which we call clinical failure. There are any number of studies have shown the resistance mutation can develop along with the virological failure or even before. And if you don't switch, these resistance mutations can get accumulate, can jeopardize several medications which are not being even used, based on some of those modeling studies. Also, the modeling studies have shown the duration between virological failure to clinical failure can be anything from 6 months to 2 years, and also from virological failure to immunological failure can be anything from more than 6 months to 2 years. So hence, the viral load monitoring is paramount in an antiretroviral therapeutics to make sure that patients are taking the drugs, they're virologically suppressed, they're not failing these therapy. Now, a little word about resistance before I talk about various resistance mutations to various lines of therapy. So this develops under suboptimal drug pressure, and the mutations can happen at the reverse transcriptase region, a protease, or to an integrase gene. And once they develop, they are permanently being archived. And some drugs have very low genetic barrier, like nevirapine and efavirenz, like NNRT containing therapy. And also, you can have a class cross resistance. For example, in the past, we used a lot of AZT. When someone uses, they develop a resistance, then they also been resistance to D40, which again, these drugs, we don't use it anymore. And also, there are modeling studies have shown there's an increasing degree if the patient continues on a failing regimen. So for this, we need appropriate viral load monitoring. And if they're not get suppressed, they need to be switched to the next line of therapy. Otherwise, it can jeopardize future regimens. So coming to those baseline resistance in different regions. So this is a data which has been reported in the WHO 2019 HIV drug resistance report, which has been updated every couple of years by World Health Organization by collecting data across the region, where it very clearly shows the majority of the regions where NNRTA resistance have been gone, either to 10% or even more, whereas shown, in these, graphs. So, and also in regions like in Asia, it's been around 5 to 15%, depending upon the region. And my own country of India, based on the available evidence, it could be anything from 5 to 10%. So that means the NNRTI regimen, which many of those regions heavily use as part of the first-line therapy as TLE, tenofovir, lamivudine, efavirenz, may not be used in these patient populations or in these regions where they have high baseline NNRTA resistance. So following this, World Health Organization has released this bunch of guidelines, especially in regions where they have more than 10% baseline NNRTA resistance, consider non-NNRTA containing therapy to initiate, preferably dolutegravir. And following this, most of the regions, when they reported more than 10%, they moved to dolutegravir containing regimen. And today, it is a universal regimen of tenofovir, lamivudine, dolutegravir to initiate treatment, as I said earlier, from the recommendation even in 2019. Now, moving focus from the first line failure to second line. So this is a regimen which has been heavily used in resource-limited settings, a combination with the tenofovir, with the lamivudine or emtricitabine, with the efavirenz as TLE as a fixed dose combination. Also, the regions in the past have used the AZT, 3DC, and nevirapine, or in small numbers with the abacavir containing therapy. So when they failed this tenofovir containing therapy with the TLE, so these are the possible mutations one can expect. One of the first mutation occurs to the mutations to lamivudine or emtricitabine as M184V. And if the patients are not identified as failed and switched, then they develop the resistance mutations to NNRTI, that is to efavirenz or nevirapine. And again, these failure is not identified and switched, then these individuals develop mutations to tenofovir as K6V or as a signature mutation. So what someone who fails these antiretroviral therapy with the first line, based on these mutation to switches, again in the second line regimen, they should have at least three drugs. At least 2 should be active therapy, and 1 from new class. It should be either an integrase or one of those boosted protease inhibitor if the initial therapy is an NRTA containing therapy. And the 2 NRTAs in the backbone should be selected based on the resistance. Ideal situation is to do a resistant testing, but in a public health setting as well as a resource setting, that's not possible. So it's better to speculate what could be the anticipate, what is a possible resistance one can harbor on that, and based on that, you can switch therapy. So someone who's been started on TLE, which is again, majority of the world have initiated in the past and they have been failing therapy. And you can consider switching them to 2 NRTIs. The earlier guidelines recommend you have to optimize from tenofovir to another NRTA to AZT, and you need to consider either an integrase or one of those protease inhibitors. This is something what's been recommended in the earlier guidelines on switching in a public health setting when someone failed therapy. So coming to this AZT, where again, as many of us know that it is twice daily and also being moved out of the first line because of the toxicity. And again, many of those clinicians are not being comfortable to use this even as part of the second line therapy when someone fails tenofovir containing therapy. Is there any possible options? To answer this, there are 3 different clinical trials was carried out. One is called the second line trial. Another one's SELECT, which is funded by NIH, called ACTG 5273. And the third study is an EARNEST study, which was been Africa-specific study. So in these clinical trials where patients who have been NNRTA resistant for first-line failure were recruited, and they're randomized into 2 different groups. One group received 2 NRTIs and a booster lopinavir, which is a standard of care for switching from first-line failure to the second line. And the test arm is a combination of an integrase inhibitor, that is raltegravir, which is again, the study was carried out before the launch of dolutegravir with the boosted lopinavir. So in that second line study, which recruited 541 patients across the different continents, Now, very clearly shows that there is no difference between a combination of two NRTIs and boosted lopinavir versus an integrase inhibitor raltegravir with boosted lopinavir, where very clearly shows that both are equally been efficacious. This has been well supported by the study published from Africa, the UNO study, and also by the ACTG 5273, the SELECT, which very clearly shows that a combination of NRTA sparing regimen with a boosted PI and an integrase is non-inferior to two NRTIs and boosted lopinavir. The following those guidelines also started recommending this particular combination as an alternate to second line regimen, where you cannot use the NRTI as part of the second line therapy because of the toxicity or because of various other issues. Now, coming to those usage of the protease inhibitors, so most of the world's been using either adazinavir or lopinavir, but darunavir has been available because various reasons it's not been used, because not widely available or because of the cost. Then what about these integrase inhibitors like dolutegravir as part of those second line, which now been recommended in the guidelines? This was based on this fact from this Dawning study, which again is a study which was carried out among patients with the NNRTI failures, where it was been randomized to two different groups. One group received two NRTIs and dolutegravir, which was compared against standard of care of two NRTIs versus lopinavir. The study went up to 52 weeks. So I'll show you the first 24-week data, the snapshot analysis. Very clearly shows participants who are on with dolutegravir-containing therapy, as shown by these blue color bars, so who got a higher virological success as compared to lopinavir-containing therapy with the two NRTIs. This very clearly shows a combination of two NRTIs with dolutegravir is superior to two NRTIs with lopinavir. Thereby, this clear guidance came from this particular study that a combination of two NRTIs and dolutegravir can be preferred second-line choice when someone fails in an NRTI-containing therapy. Then come to the question on what could be the best second-line NRTI when someone who is on tenofovir should be the AZT, or can you recycle the same tenofovir? So this is a large observational study which was carried out across the globe, mainly recruited in Africa as well as in Asia, as well as in Latin America, where they recruited 1,926 patients from 36 countries, where they all had tenofovir resistance, and genotyping was being done on that. So in this particular study, the prevalence of tenofovir resistance in sub-Saharan Africa, which was almost around 50%. So in Asia, it is around 40%. So that means when someone who's on tenofovir-containing therapy, when they fail in African settings with around 50 to 55%, when you recycle, probably the therapy what you're using as a backbone with integrase, could be even like some sort of a monotherapy. For that reason, WHO recommended in the earlier guideline, when someone has been failing TLE, tenofovir with 3DC and with an efavirenz, and when they have a virological failure, optimize NRTI, that is change from tenofovir to AZT, and you can use dolutegravir, which is much potent based on this Dawning study. But if you don't do that, based on this TNRS study, because of those baseline tenofovir resistance, so it could end up in a functional dolutegravir-containing second-line monotherapy option. As we all know, DTG monotherapy in many studies, did not, work. But on the other hand, and again, the critical question being, can you switch from TLE to TLD? This is still an unanswered question among the clinicians, because we don't want to use AZT part of the second line because of the toxicity as well as twice daily. But on the other hand, because of resistance profile like in TNRS study, so what could be those best second line NRTA options? Very recently, this Nadia study presented and now been published. So this study has been carried out in 3 different African settings, in Kenya, Uganda, as well as in Zimbabwe. So it recruited 464 persons with HIV with viral load of more than 1,000 copies who had been failing in an NRTA-containing therapy, that is with the TLE, tenofovir, lamivudine, and efavirenz. And they were randomized firstly to switch to either to dolutegravir or to boosted darunavir with 800 milligram darunavir and 100 milligram of ritonavir as part of the second line. And then a second randomization to answer a very critical question on NNRTI to either to retain tenofovir or switch to AZT. So this study now presented that 92% of the people at baseline, when they recruited following failure to the first line therapy, had lemivudine resistance, and 58.5% had tenofovir resistance, similar to the data which has been shown in the TNRS study. So when this study outcome was been analyzed at week 48, among the two arms, 90% of those of the dolutegravir arm and 91% of those darunavir arm had viral load below less than 400 copies. So that means even when you have been recycling into the same arm, they couldn't find any major difference when these data was being pulled across. And also, the sub-analysis showed there is no significant difference in virological outcome according to the NRTI randomization also. So 92.3% in the tenofovir group and 89.6% in the sudocrem had viral load below less than 400 copies, and there was no difference in rate of virological rebound above 1,000 copies. It's a very interesting finding, particularly for resource-limited setting, and this study concluded stating that high-level tenofovir resistant baseline did not compromise the response to second-line treatment in participants randomized to tenofovir-containing therapy. So 94.7% of those in the tenofovir arm with intermediate or high-level resistance also had viral load below 400 copies at week 48. So this particular study, NADIA study, support the WHO recommendations of a switch to dolutegravir in second line, even if second line NRTAs had no predicted activity. Also, this study also clearly stated that a combination with the darunavir 800 and with boosted with ritonavir 100 is a robust alternate to dolutegravir in a second-line treatment option, giving an excellent virological suppression. Thereby, our earlier regimen of arachnavir and lopinavir, because of various toxicities, where darunavir could be a preferred alternate second line. The study also showed tenofovir and lemivudine can be recycled in second-line treatment, even in people with a drug resistance mutation, simplifying the process of switching the treatment for treatment program, that is from TLE to TLD. Also, very recently at CROI 2021, a very nice presentation on revamp study. What they did, this group of investigators, this study was conducted in Uganda and South Africa, where patients of 840 patients who had more than 1,000 viral load copies prior to 3 months to recruitment in the study with no prior PA exposure and no known drug resistance were randomized into two different groups. One group received a standard of care of using 2 different viral load for switching therapy. Another group received genotypic resistant testing to switch treatment. Very interestingly, this particular revamp study very clearly showed there is no difference between the standard of care of using viral load and as well as using genotyping for switching therapy over a period of month 9. So again, this particular study concluded stating that the use of genotypic resistant testing to guide management of patients experiencing initiation ART failure did not improve 9-month virological outcomes versus standard of care. Several cost-effective analyses are ongoing, but on the other hand, resistant testing has been associated with the reduced rates of resistance at a study end, which has been significant. So following these studies, in a public health setting, someone who fails TLE, that is tenofovir lemivudine efavirenz, which majority of the regions use it, and when they fail, we have been switching, where you can safely switch them to TLD. Again, recycling tenofovir and lemivudine with dolutegravir based on this NADIA study and based on all those being shown during this presentation. But on the other hand, if anyone use TLD, that is 2 NRTIs with the dolutegravir and they fail, then we have to switch them to a PI containing therapy and with the 2 NRTI options. Now moving to those third line, there is a very few data available. This is one of those very nicely conducted study called multi-octave by the ACTG group, A5288. So in this study, 550 patients who had a second line virological failure were recruited and randomized to 4 different groups where baseline genotyping had been done. People who had no resistance to PIs, they're allotted to cohort A, and based on the different resistance profile, they are allotted to cohort B, C, or D to receive those various drug regimen as part of the third line therapy. It is very interestingly, someone who has got any PI failures mutation, and based on that, if the drugs have been optimized and switched, they had a virological suppression anything from 64% to 100%. But if they don't have any resistance mutation, the same second line regimen was recycled, they had a virological success of only 44%. So this particular study very concluded stating that a combination of boosted darunavir and an integrase inhibitor, raltegravir, with or without etravirine, can be highly effective for participants with lopinavir resistant who presented with third line ART. So this is outcome of this study, which has been very important in a public health setting where, again, resistant testing is not widely being used. But if there are places where resistant testing has been available, it's better to use that, and based on that, you can the therapy based on this ACTG 5288 outcome. So today, now we have first line therapy, we have a second line, we also have a third line in a public health setting with a boosted darunavir and dolutegravir. So coming to the integrase mutations, based on the different studies, very little resistance mutation had been seen to dolutegravir and bictegravir from different clinical trials. So these are those various signature mutations one can see. Expect for dolutegravir and elbitagravir and raltegravir as shown here. Again, based on the resistance profile is available, you can sequence the therapy. Today, based on the available evidence, when someone who has got resistance mutation to any integrase inhibitors as part of the first or second line, then if you are using this integrase as part of the third line along with the darunavir, you have to double the dose. For example, someone has been already exposed to raltegravir for first line or for second line, or dolutegravir for first line, they failed. You have to double the dose of dolutegravir to 50 milligram, twice daily as part of those regimen along with the boosted PI of darunavir. So I'm going to conclude my talk stating that the success of antiretroviral therapy is taught only when the patient is ready. Today we have robust guidelines, same day start, faster starting treatment when someone who has OI, make sure that you control the opportunistic infection start within a week, what is called rapid ART starting. Now, these are all very important in a public health setting, but on the other hand, make sure that patients are also ready because we need commitment from the patients to take this medication. Stress the importance of adherence before starting and at every visit, and make sure that the viral load is suppressed. Monumental to implement viral load monitoring in all our programs. And identify failure and respond quickly. I think that's important, as we're seeing again and again from studies and modeling studies that accumulating mutation can jeopardize resistance and also can be responsible for resistant transmission. And even in don't have a resistant testing, don't worry, consider the likely resistant patterns based on various these published studies. You can speculate and anticipate and make sure that you can give the right options to these patients as shown in many of our public health guidelines as shown in the World Health Organization guidelines. I'm going to conclude my talk to all our fellow clinicians currently been practicing in the context of COVID pandemic. When you have been seeing any patients in your clinic who have been HIV positive on antiretroviral therapy, you'll be giving all these public health messages. Along with that, very importantly, make sure that they adhere to antiretroviral therapy and OI drugs. There are many studies have shown in patients who are taking antiretroviral drugs, if they have suppressed viral load and good CD4, even if they develop a COVID, they're not going to see a different progression. But on the other hand, if they have low CD4, the chance of progression in COVID disease is much faster, which we have seen in many published studies. And also, don't change the current effective non-PA-based therapy to any PA-based therapy, because there is a theory that PIs might be better drug in a COVID, but that's not true. The clinical trials have shown that PIs are not a drug for managing COVID. So hence, don't change them any effective therapy. And also make sure that they adhere to all the other comorbid medications like diabetes and hypertension, which many of our patients have as part of those NCDs, because these are the various risk factors for the progression to this COVID. With this, I'll stop my talk again. Thank you for this opportunity. Thank you very much.